Can I ask people to start taking their seats? We're going to get going on the program again here in about another minute, so please start heading for your seats. Thank you. So we'll now proceed with presentations from the FDA.
Good morning, Chairman Smith, members of the committee. Today I will be presenting the division's perspective on the results from the ANCHOR trial. I will cover the following topics: current clinical practice guidelines for lipoprotein and lipid management, the regulatory history regarding Vascepa, and ANCHOR trial design and results. As a brief aside, the safety of Vascepa has been discussed this morning. The ANCHOR safety database was previously reviewed during the initial evaluation and approval of Vascepa, and I have not planned to discuss the safety profile of Vascepa during my presentation today. Instead, the focus of this meeting is on the efficacy observed in the ANCHOR trial and placing these results in clinical context by discussing the effect of combination therapy on residual cardiovascular risk and the effect of omega-3 fatty acids on risk of cardiovascular events. As discussed earlier this morning, current management of lipoproteins and lipids has focused on LDL as the primary target of therapy. There is robust evidence that supports LDL's association with cardiovascular disease, and that pharmacological reduction of LDL, especially via statins, reduces the risk of adverse cardiovascular outcomes. Unfortunately, risk of cardiovascular events persists even in patients with low or favorable on-treatment LDL levels, suggesting other cardiovascular risk factors beyond LDL, such as hypertension, factors related to platelet aggregation and thrombosis, or perhaps other lipid-related abnormalities are contributing. Along these lines, researchers have hypothesized that further reduction of atherogenic lipoproteins, such as triglyceride-rich particles, may mitigate some of the remaining risk. The association between triglycerides and cardiovascular disease has been the subject of debate for decades. Even if one accepts that triglycerides appear to be independently associated with cardiovascular risk, it is still up for debate whether triglyceride-rich particles are on the causal pathway to cardiovascular morbidity and mortality. Although there is very compelling scientific rationale for this, the question remains whether drug-induced lowering of triglycerides will improve clinical outcomes. Keeping in mind that LDL is the primary target of therapy, this table outlines the recommended approach for secondary lipid management from the NCEP ATP3 guidelines from 2001. In patients treated to LDL goal with persistent moderate elevations in triglyceride levels, non-HDL is the secondary target with optimal lifestyle modification and consideration of pharmacotherapy via intensifying statin therapy or addition of triglyceride-lowering therapies such as niacin or fibrates. Since the publication of the ATP3 guidelines, various scientific associations have endorsed this approach, but have also pointed out the limitations of the evidence supporting these recommendations. For example, the American Diabetes Association and the American College of Cardiology Foundation, in a joint consensus statement in 2008 on lipoprotein management in patients with cardiometabolic risk, stated, "There is not yet robust evidence for incremental benefits or risks of combination therapy compared with those of monotherapy. Results of ongoing and future trials of statin niacin, statin fibrate, and statin omega-3 fatty acids will, it is hoped, help answer these questions." One of the potential pharmacotherapies mentioned in these recommendations was omega-3 fatty acids, which primarily refer to the marine-derived eicosapentaenoic acid EPA and docosahexaenoic acid DHA. While omega-3 fatty acid mixtures are available as over-the-counter products, with variable quantities of EPA and DHA, there are 2 FDA-approved prescription products of omega-3 fatty acids approved for the treatment of severe hypertriglyceridemia, defined as a triglyceride level of 500 or higher. Lavazza, which is comprised of 375 milligrams ethyl esters of DHA and 460 milligrams ethyl esters of EPA in a 1-gram capsule, was approved in 2004. And Vascepa, also available in a 1-gram capsule, contains approximately a gram of purified ethyl esters of EPA alone, or roughly twice the amount of EPA found in Lavazza. Discussions between the division and the sponsor regarding the development of Vascepa for dyslipidemia began in 2008. 2 patient populations were proposed to be treated with Vascepa in clinical trials: patients with severe hypertriglyceridemia and patients with high triglycerides, defined as triglycerides greater than 200, not controlled by diet and statin therapy. In regards to the population with persistently high triglycerides on statin therapy, the minutes from this meeting reflect the division's uncertainty, which was conveyed to the sponsor regarding whether pharmacological reduction of non-HDL or triglycerides would translate into additional cardiovascular benefit among patients already treated with statins. Specifically, the sponsor was told the AIM-HIGH, ACCORD, and APPROVE-IT studies will provide important information on the incremental benefit of adding a second lipid-active drug to statin therapy. Furthermore, the division stated before accepting an application for a treatment indication in this population, at a minimum, a cardiovascular outcomes trial needs to be well underway at the time of review of the 12-week lipid endpoint study. In 2009, the ANCHOR trial was initiated. In 2010, the results of the ACCORD lipid trial were published. This trial studied the effect of adding fenofibrate onto open-label simvastatin therapy on cardiovascular outcomes. Addition of fenofibrate did not show any treatment benefit on cardiovascular outcomes over simvastatin monotherapy. In 2011, the results of the AIM-HIGH trial were published. This trial studied the effect of adding a second lipid-altering agent, this time extended-release niacin, to simvastatin therapy on cardiovascular outcomes in people at high risk for cardiovascular events. No significant incremental treatment benefit with extended-release niacin was observed. In 2011, the sponsor submitted their application for approval of Vascepa for the treatment of severe hypertriglyceridemia, which was licensed for marketing in 2012. In July 2012, based on the pivotal efficacy trial MARINE, which studied 229 patients with severe hypertriglyceridemia, Vascepa 4 grams per day was approved as an adjunct to diet to reduce triglycerides in adult patients with severe hypertriglyceridemia. It should be noted that the approval for severe hypertriglyceridemia should not be considered an endorsement that treatment is expected to reduce cardiovascular risk. Instead, the division has historically approved drugs for severe hypertriglyceridemia on the premise that treating severe elevations in triglycerides would be expected to reduce the risk of acute pancreatitis. There are estimated to be approximately 3.4 million adults in the United States with severe hypertriglyceridemia. A month after the sponsor submitted the ANCHOR trial for review, results from a third cardiovascular outcomes trial using a second lipid-active drug to patients already well treated with statins, HBS2 Thrive, were presented at the American College of Cardiology annual meeting, and consistent with ACCORD and AIM-HIGH, showed no further reduction in risk for adverse cardiovascular events over statin monotherapy. In February of 2013, the sponsor submitted the ANCHOR trial to support the following treatment indication. Vascepa 4 grams per day is indicated as an adjunct to diet and in combination with a statin to reduce triglycerides, non-HDL, ApoB, LDL, total cholesterol, and VLDL in adult patients with mixed dyslipidemia and coronary heart disease, or coronary heart disease risk equivalent as defined on the slide. It is estimated that 21% of U.S. adults have mixed dyslipidemia, although the number who actually meet the criteria described in the proposed indication is presumed to be less. Although the indication strictly speaks to reduction in lipoprotein levels and improvement in numbers, this indication for this population certainly implies that one should expect cardiovascular benefit from treatment. The study design of ANCHOR is similar to other trials designed to evaluate a study drug's effect on triglyceride, with dietary lead-in periods, statin stabilization, and non-statin lipid medication washout components prior to randomization. Roughly 2,300 individuals were screened to randomize 702. The box on the upper left of the screen shows the primary reasons for screen exclusion. The majority of patients were excluded for not meeting the triglyceride entry criterion. 6% of patients withdrew consent before randomization, and 1% was lost to follow-up during the screening period. The trial was equally allocated between placebo and 2 and 4 grams of Vascepa. A slightly higher proportion of placebo-treated patients discontinued from the study, but the discontinuation rates were low across all treatment groups. The primary efficacy analysis population was conducted in a modified intent-to-treat population defined as patients with a baseline and at least one post-randomization laboratory value. While the briefing materials describe the results of the 2-gram daily treatment group, this presentation will focus on the results within the Vascepa 4-gram treatment group compared to the placebo group, as this is the recommended daily dose proposed by the sponsor. The baseline characteristics of the randomized ANCHOR participants are shown here. The treatment groups were well matched. The mean age was 61. The majority of participants were men. 73% had diabetes. Over 80% had hypertension, and a third had a history of cardiovascular disease. Very few participants identified as non-Caucasian. Only 12 African American individuals were randomized to participate in ANCHOR. The small numbers of non-Caucasians limits the generalizability of ANCHOR's results to other racial groups. Median baseline values of the primary, secondary, and selected exploratory efficacy lipid and lipoprotein endpoints are shown here. Qualification for study participation required average triglyceride levels greater than 200 and LDL values less than 100. These requirements are reflected in the median baseline values of the ANCHOR trial participants. Overall, median triglyceride values in the randomized population at baseline were 260 and LDL values were 83. This box and whisker plot displays the distributions in percent change from baseline to week 12 of the primary efficacy endpoint, fasting triglycerides. Using the Hodges-Lehmann statistical method, the estimated median treatment difference between the Vascepa 4-gram treated group and placebo-treated group was 21.5 percentage points. This figure summarizes the median percent change from baseline to week 12 for the primary, secondary, and selected exploratory lipid and lipoprotein endpoints in the placebo-treated group in the gray bars and Vascepa 4-gram treated group in blue within the modified intent-to-treat population of ANCHOR. All between-group differences were statistically significant. The figure shows that with the exception of HDL, the changes observed within the placebo group went in an adverse direction from baseline to week 12. The direction and magnitude of these changes in the placebo group were unexpected, given the study design, which incorporated a substantial lead-in period of dietary instruction and statin stabilization prior to randomization. As a reminder, the placebo group received 2 milliliters of mineral oil twice a day. The division recognizes that in placebo-controlled trials, it is the between-group differences that are assumed to estimate the treatment effects. This assumes, however, that the placebo is inert and no other factor is differentially affecting the placebo group versus the active group, which could affect the outcome. In the case of Anchor, however, the changes observed within the placebo group stood out as atypical for similarly designed lipid-lowering trials that we have reviewed, which gave us pause, especially since the changes went in an unfavorable direction. Thus, the review team sought evidence that might help explain the changes observed in the mineral oil group. We considered issues with randomization, unblinding, statin absorption, study design elements, and lipid changes observed in placebo-treated patients. Our review did not point to any particular cause for the observed placebo changes. Therefore, what, if any, implications do the placebo group changes have on the REDUCE-IT and Anchor trials? For REDUCE-IT, our primary concern was whether or not there was a possibility that the mineral oil could attenuate the effect of a statin, perhaps by inhibiting absorption. If plausible, this would raise concerns about the potential impact this would have on the ongoing cardiovascular outcomes trial, which is also using mineral oil as placebo among statin-treated patients. Because we do not have any hard evidence for an interaction, such as a formal drug-drug interaction study, we discussed our concern with the sponsor and asked that they task the REDUCE-IT Data Monitoring Committee with evaluating the accruing lipid data with this concern in mind. What implications are there, if any, for the Anchor trial? There could be none. If one believes that all elements affecting outcomes in the Anchor trial were equally distributed between the placebo and active groups, then the between-group comparisons represent the best estimate of the treatment effect, shown in the far right column of this table. Alternatively, if one believes that the changes within the placebo group could be a result of some factor that is not also present in the active groups, then the treatment effect of Vascepa may be overestimated. This may or may not affect your interpretation of whether these results would be expected to translate into a benefit on clinical outcomes. These possible implications may be kept in mind when considering the following summary statements regarding efficacy in the Anchor trial. 12 weeks of treatment with Vascepa 4 grams per day led to a reduction in the primary efficacy endpoint triglycerides compared with the mineral oil placebo among statin-treated patients with mixed dyslipidemia at high cardiovascular risk. The reduction in triglycerides observed with Vascepa was not associated with elevations in LDL levels relative to placebo. Other lipoprotein parameters changed with Vascepa treatment in a favorable direction. However, the critical question which patients care about is ultimately, do the observed changes in lipids and lipoproteins with Vascepa while treated with statins translate into a benefit on cardiovascular outcomes? This question is not new, but now we have more data informing this debate. This morning you've heard the sponsor cite several associations between triglyceride or non-HDL and cardiovascular outcomes. In general, we agree that several studies suggest an association between these lipid parameters and outcomes. Such associations, however, are but one piece of the story. There have been multiple instances when a drug has had no effect or even adverse effects on clinical outcomes, despite beneficial effects on biomarkers that have been strongly associated with clinical events. To this end, we believe that recent clinical trials inform the discussion. Several groups have investigated the effect of adding a second lipid-active drug to statin therapy on cardiovascular events, and recently reported the results of adding fenofibrate in the Accord lipid trial, extended-release niacin in the AIM-HIGH trial, and extended-release niacin in combination with an anti-flushing agent in the HPS-2 Thrive study. The Accord lipid study was designed to answer the following question. In patients with type 2 diabetes who are at high risk for having a cardiovascular event, does a therapeutic strategy that uses a fibrate to raise HDL and lower triglyceride levels, in addition to statin therapy, reduce the rate of cardiovascular events compared to a strategy that uses statin therapy alone? The primary outcome was major cardiovascular events, defined as cardiovascular death, non-fatal MI, and non-fatal stroke. Approximately 5,500 patients with type 2 diabetes were randomized to either simvastatin plus fenofibrate or simvastatin alone. The mean follow-up period was almost 5 years. Treatment groups were well matched. There was no lower limit for triglycerides to qualify for participation in Accord lipid, which is reflected in the relatively low median baseline triglyceride level of 162. The mean HDL and LDL values were 38 and 101 respectively. At study N, patients treated with the combination of simvastatin plus fenofibrate demonstrated numerically favorable changes in triglyceride and HDL compared to simvastatin alone. However, the addition of fenofibrate to simvastatin in this population of diabetics at high cardiovascular risk did not significantly improve cardiovascular outcomes beyond simvastatin therapy alone. The objective of the AIM-HIGH trial was to determine whether the residual risk associated with low HDL levels would be mitigated with use of extended-release niacin in patients with coronary heart disease whose LDL levels were already optimized through statin use. Approximately 3,400 patients were randomized to either simvastatin plus extended-release niacin or simvastatin plus placebo. The primary endpoint was coronary heart disease death, non-fatal MI, stroke, hospitalization for acute coronary syndrome, or symptom-driven coronary or cerebral revascularization. Baseline median values for triglyceride was 161, HDL was 35, and LDL was 71 in patients on statins at entry. At 2 years compared with simvastatin monotherapy, the niacin plus simvastatin treated group showed a greater reduction in triglycerides. Median HDL levels increased by 25% from baseline for patients in the combination therapy arm versus 10% increase from baseline in the simvastatin monotherapy arm. The trial, however, was stopped after an average of 36 months of follow-up because of the lack of evidence of efficacy. Treatment with the combination of extended-release niacin plus simvastatin therapy versus simvastatin monotherapy did not result in a significant reduction in major cardiovascular events. Most recently, THRIVE, a much larger trial than AIM-HIGH, reported the effect of extended-release niacin in combination with an anti-flushing agent, laroprant, on top of optimal statin therapy and LDL control. These results are preliminary and have not been fully peer-reviewed and published in the scientific literature or officially reviewed by our division. The available public information on THRIVE reported enrollment of over 25,000 patients considered to be at high risk for cardiovascular events. The primary outcome was major vascular events, defined as coronary death, non-fatal MI, stroke, or revascularization. At baseline, triglycerides were 125, HDL values were 44, and LDL values were 63. At a median follow-up of 3.9 years, the average treatment difference of extended-release niacin plus laroprant on lipids was approximately 33 milligrams per deciliter for triglycerides and 6 milligrams per deciliter in HDL. The combination of extended-release niacin and laroprant to statin therapy did not significantly further reduce the risk of major vascular events versus statin therapy alone. We acknowledge that all studies, including these highlighted, have limitations. However, to date, there is no conclusive evidence that additional modifications of non-LDL lipid and lipoproteins translate into further cardiovascular benefit in the setting of optimized statin therapy and LDL control in the overall population study. We are aware of analyses of certain patient subgroups defined by baseline triglyceride and HDL level thresholds in Accord Lipid and AIM-HIGH, which have suggested a possible treatment benefit with add-on therapy to statins. However, these positive subgroup results in an overall negative trial should be interpreted with caution. The division considers these results to be hypothesis-generating and have not been confirmed in prospective randomized placebo-controlled trials with cardiovascular event endpoints. Admittedly, the trials just discussed have not tested the effects of omega-3 fatty acids, and some argue that there exists compelling evidence that omega-3 fatty acids, have a beneficial effect on cardiovascular outcomes. Epidemiological literature dating back nearly 40 years has, in fact, associated higher fish consumption with a lower risk of cardiovascular events. Even a randomized controlled trial conducted in the 1980s, the DART trial, suggested that receiving dietary advice to increase fish intake relatively soon after an MI improves cardiovascular outcomes and even all-cause death. During the 1990s, the GCP trial aimed to determine the independent and combined effects of omega-3 fatty acids and vitamin E on morbidity and mortality after MI. This open-label trial involved more than 11,000 patients with a recent myocardial infarction, less than 5% of whom were taking statins at baseline, and suggested that supplementation with approximately 1 gram of combined EPA and DHA ethyl esters provides a mortality benefit, predominantly from cardiovascular causes. Interestingly, the trial did not suggest an effect on the incidence of non-fatal cardiovascular events, and the effect of omega-3 fatty acids on lipids, including serum triglycerides, were negligible. In fact, this trial provided support for the hypothesis that omega-3 fatty acids likely exert their cardioprotective effects through non-lipid-mediated mechanisms. These secondary prevention trials were followed by the JELIS trial, also open-label, which sought to test whether highly purified EPA ethyl ester, when added to a statin, would reduce major coronary events among Japanese subjects, 80% of whom were being treated as primary prevention. This trial will be discussed in more detail in a moment, but in short, the trial suggested a 19% relative risk reduction in major coronary events with 1.8 grams daily of purified EPA ethyl ester. Unfortunately, following these two open-label trials, multiple double-blind randomized controlled cardiovascular outcomes trials have largely failed to confirm the benefits suggested by GCP and JELIS, with several reporting results within just the last few years. GCHF suggested a modest benefit on mortality in patients with heart failure. OMEGA aimed to validate the presumed antiarrhythmic properties of 1 gram per day of omega-3 fatty acids after MI among patients receiving contemporary care. This trial failed to demonstrate an effect on sudden cardiac death or on several cardiovascular secondary outcomes. Alpha Omega was specifically designed to test whether low doses of EPA and DHA, the plant-derived omega-3 fatty acid alpha-linolenic acid, or both, reduced the risk of cardiovascular events among patients with a history of MI. The low dose was chosen based on results from a meta-analysis of cohort studies and clinical trials that suggested no additional cardiovascular benefit once one achieved a daily intake of 250 milligrams of EPA and DHA. The next trial, also conducted in a secondary prevention setting, failed to demonstrate an effect on its primary endpoint, although a relatively low dose of EPA and DHA was also used in this trial. The most recent trials, the ORIGIN and the Risk and Prevention trials, were randomized, double-blind, placebo-controlled trials that each enrolled more than 12,000 patients and used 1 gram daily of EPA and DHA ethyl esters. ORIGIN enrolled patients at high risk for cardiovascular events who had dysglycemia, and RMP enrolled patients with multiple cardiovascular risk factors or atherosclerotic vascular disease, but without a history of myocardial infarction. Triglycerides were statistically significantly reduced in these trials, without substantial changes in other reported lipid parameters. And although it is difficult to make cross-trial comparisons using the published data, it appears that the changes in triglycerides in these trials were likely greater than the changes observed in the earlier GCP and JELIS trials. As you can see, both of these trials failed to demonstrate an effect on their primary endpoints. Secondary cardiovascular endpoints did not suggest beneficial treatment effects in these trials either. These trials do come with limitations. All use lower doses of omega-3 fatty acids than what the sponsor suggests is an effective dose. Background therapy varied dramatically, although it is notable that the more contemporary trials in which statin use was more frequent have certainly not suggested a benefit of omega-3 fatty acids at the doses tested. It's possible that, similar to the results of Accord Lipid, Aim High, and Thrive, a typical patient who is well treated with a statin may not gain incremental benefit from omega-3 fatty acids. Often these trials have also had event rates that were lower than expected when sample sizes were calculated, limiting the power of some of these studies. Nevertheless, it should at least give us pause that it is the open-label trials that were conducted in the absence of optimal cardiovascular prevention strategies based on today's standards that provide the most suggestion of benefit. Next, I'd like to discuss the JELIS trial in more detail, since this trial used purified EPA at almost 2 grams per day, which is the highest dose of any of the listed trials, and because it was a cardiovascular outcomes trial that added EPA to standardized statin therapy. The JELIS investigators randomized 18,645 Japanese adults with elevated cholesterol with or without coronary artery disease to open-label treatment after a 4 to 8 week washout period of either 1.8 grams per day of EPA plus pravastatin 10 milligrams or simvastatin 5 milligrams per day versus one of these statins alone. The study population was exclusively Japanese. 2/3 were women. The mean age was 61 years old, and only 20% had a history of coronary artery disease. LDL levels were 182 milligrams per deciliter, and triglycerides were 154 at baseline. The primary endpoint was a major coronary event defined as sudden cardiac death, fatal or non-fatal MI, unstable angina, and coronary bypass surgery or angioplasty. This slide shows the changes in lipids between the two treatment groups at study N. LDL decreased in both groups from baseline by 25%. There was only a 5 percentage point difference in triglycerides between the two groups, which was statistically significant. The 5-year cumulative rate of major coronary events was 2.8% in the EPA plus statin group and 3.5% in the statin alone group, resulting in a significant relative risk reduction of 19%. The breakdown of the individual components of the primary endpoint shows the strongest evidence of the treatment effect with EPA on unstable angina. There are several limitations to the JELIS study. First, the patient population was exclusively Japanese. The majority of the participants were women, and at baseline, patients had a much higher LDL, limiting its generalizability to the intended target population. Second, a low dose of statins was used. It is unknown if these patients had been optimally treated with statins using contemporary LDL targets in the United States, whether the positive treatment effects would have persisted. Third, JELIS was an open-label trial, which could influence patient and physician behavior in reporting of symptoms, decisions regarding hospitalization, and referral of events for adjudication. This may be particularly relevant since hospitalizations for unstable angina was a primary contributor of the overall positive result and is considered a softer endpoint than fatal cardiovascular events. Finally, in order to approve the indication we are discussing today, we need to be confident that the changes in lipids observed in ANCHOR will translate into cardiovascular benefit. The relevance of a single open-label cardiovascular outcomes trial conducted in Japan that has not been submitted to the Division for Independent Review is questionable. In part, the issues just discussed regarding the applicability of the results of the JELIS trial to the U.S. population prompted the division to request that a cardiovascular outcomes trial be conducted to provide definitive conclusions regarding the addition of EPA to statins on cardiovascular events. As discussed earlier, REDUCE-IT will compare the effect of 4 grams of Vascepa versus a mineral oil placebo in 8,000 high-risk statin-treated patients with elevated triglyceride on occurrence of cardiovascular events. This event-driven trial started almost 2 years ago. 1,612 events are needed to detect with 90% power a 15% decrease in the primary endpoint, defined as a composite of cardiovascular death, MI, stroke, coronary revascularization, and unstable angina. In conclusion, treatment with 12 weeks of Vascepa 4 grams per day versus mineral oil placebo demonstrated statistically significant improvement in triglyceride and other lipids and lipoproteins in statin-treated patients. Recent cardiovascular outcomes trials with fenofibrate and niacin call into question whether targeting lipids and lipoproteins other than LDL yield incremental cardiovascular benefit in the setting of contemporary statin therapy. Cardiovascular outcomes trials with omega-3 fatty acids do not consistently support benefit. Thus, whether the lipid changes, specifically triglyceride and non-HDL, observed in the ANCHOR study will translate into lower rates of major adverse cardiovascular events is debatable. REDUCE-IT is ongoing and will assess whether treatment with Vascepa improves clinical outcomes among statin-treated patients with residually elevated triglycerides.
Thank you, Dr. Roberts. We're now open in this part of the schedule today for clarifying questions. Dr. Hyatt.
So I'd like to ask the FDA whether you think the ANCHOR safety database is adequate. And the reason I ask that is that the proposed label is to treat a surrogate endpoint, as you say, with the presumption that there's clinical benefit. But the issue on the table today is whether we should approve something on a surrogate endpoint. In my mind, if that's the question, then the safety database has to be really good. And it should rule out things, as were mentioned earlier today, such as worsening glycemic control, transitioning people from prediabetes to diabetes, or causing major and minor bleeds. And the background in both the sponsor and your document don't really say much about it. And I just want to know if you all think that's adequate for approval for this indication.
So if I hear you correctly, you're asking if the safety database is adequate to approve this indication?
Correct.
Well, I think first, I would want to look first at the efficacy of the trial first to make sure that you are comfortable with the observed lipid and lipoproteins changes that you've seen in the ANCHOR trial. And I definitely think safety needs to play into it in part, but I wouldn't necessarily want to give somebody a pass because they feel like the safety may be not as significant as some other drug. I would want to focus first on whether or not I was comfortable looking at these changes and whether or not I thought the changes I observed would translate into a clinically meaningful benefit first. And then I would look at the safety database. Part of the reason we have you guys come is to give us these, to look at it with new eyes, to look at the look at the safety database. Certainly, what I'm hearing from you today is that there may be concern about some of the glucose changes. And I can say that it may not be, in a 12-week study, that may not be enough time to formulate your final conclusions about the glucose changes that you're observing. Certainly, the REDUCE-IT trial is going to give us more information about that. But thus far, what we have are two 12-week studies that we've looked at. I can show you when the initial evaluation of Vascepa. Hold on one second.
So I get that. That's not my question. My question is, at the end of the day, we're going to judge something on risk and benefit, right? So clearly, the drug significantly lowers triglyceride levels, and you focused on efficacy. And that is fine. My question is, from a regulatory perspective, do you think the safety database is adequate? You didn't even present it. And I'm asking you to judge collectively, why we're here today if we're trying to prove something on a surrogate endpoint, not a clinically relevant endpoint, a surrogate endpoint with a really sparse safety database. And we can discuss concerning about it later in the day, and I think we probably will. But I want to ask you, again, do you think the safety has been adequately described to approve this labeled indication?
I think that based on the information that we have available today, there wasn't, upon our review, a concerning safety signal that was seen to be new based on the class and on this particular drug. So that's what
That's what I figured. And just to point out, though, that it's a short exposure. It's not many patients. There aren't many safety events, and therefore you're sort of assuming the absence of evidence is evidence of safety. And I just am asking that question. I guess I can sort of table it for now, but that's my concern.
Diana Hiller, you had a comment or question earlier. I'm sorry, I forgot to bring you in at the beginning of this session. Do you still have a comment or question you wanted to make?
I would like to ask about the subcategories. I mean, we mostly talked about diabetes, but how about hypertension, and which of the CHD risk factors, or for instance, history of CHD, would be most impacted negatively or positively by Vascepa or any of these other trials?
So I think you were wanting to know about like the subgroup analyses and which groups may have not done as well. Is that what you're? I just want to make sure I understand your question first.
One of the questions is basically the subgroups with regards to whether, for instance, if there's a correlation with diabetes, hypertension, and CHD, for instance, with regards to history, if there would be if it would be more impacted with regards to triglycerides or with regards to the HDL or so because of Vascepa, and also if there are any, I mean, there were drug interactions probably that may or may not have been included, but I did not see for hypertension.
I believe that, I'm not sure if the sponsor did a pre-specified subgroup analysis on baseline blood pressure. I don't recall off the top of my head. They're shaking no, so I can't speak to whether or not the treatment effect based on whether you had hypertension or not altered how you responded to the drug. Over 80% of the patients in the population were hypertensive. And what I recall from looking at the subgroup analyses is that there wasn't any particular subgroup that did significantly worse or better on treatment. The sponsor can confirm that if they wish.
Dr. Britton.
Yes, that is. I can clarify that that's correct. I'd like Dr. Brent Blumenstein to present a slide that shows we did look at a broad category of patients in terms of, if you like, predicting who might benefit more from the therapy.
So we showed these kind of forest graphs earlier. Here we have broken down by hypertension versus not. And as you can see, there's no material difference between the hypertensive versus non-hypertensives.
Okay, now, Dr. Britton.
Yeah, my question is about slide 28. The sponsor made a big point about the fact that the doses are different in the different than what they're recommending. Were the triglyceride and other parameter differences between the treatment groups the same here as on the same order of magnitude as was observed in the Anchor study? And is there any relationship between the treatment, the difference in the triglycerides and the primary outcome that you're putting on this slide.
I think what was noticeable, particularly like in the JELIS trial, is that there wasn't much difference in the lipid parameters. I mean, there was only like a 5% treatment difference in the triglycerides, and yet there was a 19% reduction in relative risk. I believe in the later trials, like Origin and Risk and Prevention, they had statistically significant differences between the two groups in triglycerides. I am not certain about the magnitude if they correlate specifically with the Anchor trial. Is that what you're referring to? Okay. Yeah, I can look that up, or I can defer it to my colleague here.
Well, and remember, GCP hardly had really any difference in triglycerides, and that was a positive trial as well. It's difficult. They weren't all reported. I mean, we just have the published literature for these, and they weren't all reported on the same scale. You know, we can't infer a percent change from baseline when we just have a median baseline value and a median baseline to follow up and some absolute changes. So it's hard to say. It seems that Origin and Risk and Prevention, some of the more recent trials, it seems that those actually probably had larger changes in triglycerides despite failing to meet the primary endpoint. But we can't say for certain, and we certainly don't have patient-level data to explore that. I mean, you raise a very good point, because it's one thing whether triglycerides, for example, associate with outcome. But a lot of things come along with triglycerides, right? I mean, obesity, insulin resistance, and a lot of things. So is it the triglycerides, as Mary mentioned, is that on the causal pathway, or is it something else? And so, you know, one way to also look at not only on treatment values of absolute values, but look at, does a change in a lipid value correlate with a reduction in risk? And in the studies that have been done today, now Dr. Miller shared the Prove It data that does suggest that a change in triglycerides, even in multivariate analysis, correlates reduction in risk. But that hasn't been consistent across trials for whatever reason. In fact, in 2000, I think it was 2009, there was a meta-analysis. The lead author, Briel at McMaster University, and Gordon Guyett looked at 108 clinical trials, so almost 300,000 patients. And the paper primarily focused on HDL, but within that paper, they make the comment that change in triglyceride in these trials, and this was study-level comparisons, so there's a limitation there, but change in triglycerides was not significantly associated with risk reduction once you adjusted for change in LDL. And so it's a murky association, we think, and it's a big reason why you're here to help us tease that out.
So I would like to ask a question from anybody who can help me out here that is a little bit related to the discussion we just had. And that is, as I've looked at the data that we've been shown and also reviewed the requested indication, I see what we were calling surrogate endpoints, triglyceride being the dominant example. But there are multiple other lipid endpoints that we've been seeing data on that are in the requested indication, I understand. And so my question is, and they all have different percent effects that have been observed in the data that we've been seeing. And so what I'm looking for help with is how to manage. I'm not going to ask you the harder question, which is what's the relevance of each of those endpoints to cardiovascular outcomes, but just looking at the differences that we're seeing, how should we manage those percent differences? Can you provide any help on that? So, for example, if I compare something like ApoA1 versus triglyceride, should I think about a percent change in any other way as I try to speculate or think about the potential clinical significance of those changes?
If you'll permit me, I'd like to first ask the company if they could explain what went into the decision to put those various parameters in the indication.
So we factored in existing labels from other lipid-lowering therapies in terms of the types of parameters mentioned in their indication statements and or in the data tables within the label. So that was the rationale for the proposed indication. Obviously, we have, the application is still under review. We need to dialogue with the FDA, team in terms of ultimately arriving at the label. But the hierarchy of the importance is clearly triglycerides without impacting LDL and non-HDLC for the reasons mentioned earlier by Dr. Miller and others is another key endpoint. We obviously affected a broad range of lipid and lipoprotein and inflammatory markers, but the most important endpoints to focus on are TG, LDLC, and non-HDLC.
Yeah, so this really does involve years and years of labeling precedent just moving forward. If you were to look at the labels for the statins, the indication would be similar to what Amarin's proposing. We have traditionally focused on LDL, where we wanted to see a specific minimal difference between placebo and drug for LDL reduction. To my knowledge, we haven't done that for any of the other parameters that are listed in the indication. They kind of ride along with LDL, and it really just reflects how this has been done in the past.
Yeah, I had sort of anticipated that, and what I think I'm asking an impossible question, but it's one that I'm not asking it for sport. It's something that I'm also once shown the numbers that one has to think about, which is really whether there are any data, there's any evidence that would perhaps argue for us to think differently about a 20% change in a triglyceride level as compared to a 2% change in the level of another lipid parameter, and whether we have something that should suggest to us that perhaps the 2% is as important as the 20% in terms of changes that occur in that endpoint that via associative studies or something may have some interest. And I realize it's a very hard question, but that's why I said anybody here who might have something that might be useful to guide that. Otherwise, it's very hard to know how to think about those other changes. Jim, you had a comment, and then Peter too.
Well, maybe Dr. Wilson's going to address your question, or otherwise
I might try. So I think part of it, Bob, where we are now is we have patients all the time with LDL cholesterols in these trials under 100. They're typically 70 and 80, all these most recent trials. And taking meta-analyses that have gone across the spectrum don't really get at this modern era where everybody who is in a trial is getting at least entry-level, often moderate-level statin, and then a second agent is being added. And so now almost every second agent has been a null result except for subgroups. And some of the subgroups, of course, have been pre-specified beforehand, which has helped those trials. But as Eric Coleman mentioned earlier, how do you interpret a trial where the overall result was null and the subgroup was positive? In fact, we had many years ago the Helsinki trial, which was also elements of triglyceride lowering. The overall result was positive, and the subgroups, some of them were positive and some of them were negative. It helped sort out the field where the fibrates were working. But that was a good example of an overall positive because of the trial, but then a subgroup also positive. Where I'm wrestling with, and I think those of us endocrinologists and those in lipid clinics, are the changes, and everybody has, this is table 1 in everybody's handout, is the LDL and the VLDL and the non-HDL. And then, unfortunately, all the placebo, gosh, I wish we didn't have the placebo here. That was one of my asides is going to be, I need a better placebo for omega-3 trials. maybe a micro fraction of omega-3 and some non-absorbable carbohydrate, so that you have the taste of omega-3. But because these placebos confuse me more than the drugs. And I'm sitting there with my patient in clinic. He has an LDL of 80, and he may have whatever other non-HDL of 110. You add another 30 units. And I'm trying to make the decision, and the FDA put this through very effectively, I thought, in their discussions. Do you reach for escalating the statin dose and getting maybe another 6%? Or do you reach for a different class of molecule? And these results here don't help us a lot. And there are some differences, but if I just focus on the active agent, they're fairly small changes for major atherogenic lipids. And I think it's unlikely to translate into meaningful clinical benefit with just looking at that. So, but then when I put in the placebo, the picture looks a little bit rosier, but it's not as rosy as I'd like to think, even, just with the lipids. So that's my answer to your question. It's very hard, especially because of the placebos.
Dr. Smith, could I be recognized just to follow on from Dr. Wilson's comment?
Yes, that would be fine.
So just in regards to that table 1 that was just up, I think one of the underlying questions has to do with the correct characterization of the degree of efficacy in anchor. And that's where, as we presented our data, we did obviously pre-specify in a primary fashion change versus placebo. Clearly did not expect some of those observations, however you want to characterize some of the underlying aspects. But if you focus on the center column of this table, and remember that it's an add-on to statin in high-risk patients, when we look at the triglyceride reductions, the fact that LDL-C is not perturbed, and that you do see some incremental reductions in other parameters, and you remember that this is, with its safety and tolerability profile, we feel that this would be a valuable addition to the physician armamentarium. And we agree with Dr. Roberts and her colleagues in terms of the lessons to be learned from ACCORD and AIM High. And what may not have been completely obvious as we're recounting the regulatory history is that obviously we as a scientific team looked at those results as they read out. And that's why we take great pride and passion in the fact that we were able to proactively factor some of that into the REDUCE-IT outcomes trial. Specifically, when you look at these values, it's really important when you look at the sub-analyses of ACCORD and AIM High. Yes, there were some triglyceride lowering, but did those patients, were they really in the risk category where they needed triglyceride lowering? So I think as you put these numbers into perspective, it's important that in this study that the patients had triglycerides greater than or equal to 200 milligrams per deciliter. They were on a statin, and in spite of that statin therapy, they realized these incremental lipid and lipoprotein benefits. Thank you.
Jim, yeah, comment.
So I was just going to follow on to your question as well. I think that we sense your angst, and we have that too with regard to what does a percentage change in some of these things mean clinically. That's why we're here. With a lot of these endpoints, with LDL, granted largely statin treatment, but the work of groups such as the Cholesterol Treatment Trialists Association that have done large patient-level meta-analyses have sort of really helped us define what we might expect from a given change in LDL, for example. We're not aware of similar patient-level efforts to combine a lot of these trials, and frankly, some of the most useful trials might be those that are just now coming to fruition and being published. There's probably a wealth of data there that might help us down the road with those questions, but we don't know. The other thing, Stephanie, if you can show our backup slide 27. With regard to the non-HDL association and kind of Dr. Miller made the point that a 1% change in non-HDL correlates with a 1% change in CHD risk reduction. And this is from one of Jennifer Robinson's papers. And I basically graphed the same thing because she was kind enough to put all the primary data from all the trials right in table 1 of the paper. And this is that non-HDL relationship for statins, fibrates, and niacins. Now, granted, this is 2009, so we don't have everything here. But if you go to the next slide, Stephanie, this is LDL reduction versus CHD. And I didn't do any meta-regression, so I didn't put in a line. But you can see that actually you essentially have the same pattern there. But if you go to the next slide, which is change in triglycerides versus change in CHD risk reduction at the study level, you kind of lose it. You don't have that same relationship. And it sort of makes sense if you think about it, because these were not done in mixed dyslipidemic populations, so non-HDL cholesterol is largely going to be made up of LDL in those populations. So even asking this question in the mixed dyslipidemia population that Dr. Wilson points out, and if you take a mixed dyslipidemic patient who's now well treated with statin, what do some of these changes mean? I don't think we have great data for that.
Thank you. Dr. Harrell.
And I had a question about some of Dr. Roberts' slides, but on this last slides that Dr. Smith discussed, none of those slides answer the question because none of them tell us how baseline levels relate to the reduction in risk. You need to look at baseline and final to gain that.
Yeah, no, that's right. That was percentage change, but is not adjusted for baseline.
And it's not only that it's not adjusted for baseline, but you don't see whether baseline influences the change in the outcome.
Correct.
And then on Dr. Roberts, I want to look briefly at slides 25 and 30. Just a clarification, were these median changes in percent or the means?
I believe they were the median percent change from baseline for these groups.
Okay. And then slide 28, I think to be picky about the way you described that slide, you were making the absence of evidence is not evidence for absence mistake, in that you see evidence for 20% reduction in outcome for most of these studies. And so we have to look at the lower end of the confidence interval and not just the point estimate. And I think one thing that's Dr. Smith may have answered in terms of the availability of individual patient data not being there. I think we need to work hard on getting those data. And one of the key things we need to look at is whether baseline triglyceride interacts with treatment effect. Because these populations have great variety of baseline triglyceride levels.
Dr. Gregg.
Yes, I'd like to go back briefly to the issue about potential increases in glucose and even diabetes risk. One thing that stands out about the Origin trial is that the whole trial was done in people with dysglycemia or diabetes, although I'm not sure what the breakdown was. And I mean, it's over 12,000 people. Certainly the event rate should be sufficient there. I'm noticing here from our materials that they didn't report what the diabetes rate was or the change, but I'm wondering whether that has been reported subsequently or whether there's any access to that. That might actually be one of the better sources to address that concern.
I don't know that rate of just how that group of patients did in the trial. We can look at the data. I mean, what I have for the omega-3 fatty acid is just from the published literature, so I can look at that and see.
Dr. Seeley.
I wanted to go back to Dr. Hyatt's comment about lack of safety data prepared by the FDA. Most of us were not on the panel that approved Vascepa for its first indication, where I'm sure there was more safety data presented. We've heard from the sponsor some safety data, but we usually hear from the FDA some safety data. So to just say we're supposed to judge that, I don't think we have the information to judge that because this is a new indication. So the FDA's presentation of safety data is very important so that we have that weighed with what the sponsors presented as their safety data. So I think that, I'm sure you do have some safety data. I think it would be helpful for us to be able to see the safety data.
Yeah, I think that your feedback is well taken. Obviously we're this is not a new molecular entity that we're discussing, and it's approved for a population of several million patients at least. And so I think that the bottom line was that when we were comfortable with the sponsor's interpretation of their safety data, and it seemed consistent with what we had previously reviewed when especially Marine and Anchor were even pooled and considered together in the initial NDA review, as well as post-marketing data that we have received. We don't have other data to present to you, but we hear what you're saying.
Yeah, but I think even that comment is very helpful as opposed to we're supposed to judge the safety data, that you're telling us that you've looked at the safety data and that you feel comfortable with it. And I think that's part of what Dr. Hyatt was asking is, do you feel comfortable with the safety data?
Yeah, fair enough. I think that we did not see something that seemed to come up new in this re-review, because Anchor safety data was actually already reviewed by, when Vascepa was approved. And so even though Dr. Roberts did actually re-review it during this cycle, we didn't see anything else that came up that was of concern to us. So if that is helpful, that's great. Now, you may have different interpretations of that, and we welcome that. And if that comes into your discussion, and if that comes into your decision and your recommendations to us, that's why you're here.
Dr. Gutierrez, did you have a follow-up on one of the earlier points?
Yeah, this is a follow-up for Dr. Gregg, who asked about the incidence rate in Origin. It was around 2.6% for the first co-primary endpoint, which was MACE only. And then the number of patients with diabetes in Origin were 88% of the whole trial.
Dr. Everett.
Thank you. I wanted to focus a little bit on the JELIS trial because both the sponsor and the FDA has, I think, appropriately identified that as the bridge to real clinical efficacy, if you will, from biomarker to potential and impact on myocardial infarction, stroke, and cardiovascular disease. So you noted, Dr. Roberts, in your presentation that in the arm of JELIS that included statin only, that there was a 19% reduction in LDL cholesterol, and statin plus EPA, 2 grams of EPA, there was a 25% reduction. So while the on-treatment LDL levels are not presented in the manuscript, I think it's worth a back-of-the-envelope calculation, and I'd be happy to be corrected if I'm wrong here, but actually the median LDL cholesterol level in that trial at randomization was 183 milligrams per deciliter, so quite high. So a 25% reduction, so this is the statin plus EPA arm, would bring us to 137 milligrams per deciliter. And then the 19% reduction in the Simva or Prava arm only would bring us to 148 milligrams per deciliter. So as a treating clinical cardiologist, in patients who have either existing coronary heart disease or diabetes, that kind of LDL cholesterol levels I hope not to see in my clinical practice, basically. That's too high. And while the doses of statins in Japanese populations are frequently lower, I would say that that suggests that the jealous population was grossly undertreated for LDL cholesterol, and that the applicability for the kind of scenario and indication that we're talking about here is questionable. In other words, the ability to apply those data to any purported hard cardiovascular event reduction to the proposed indication is shaky. And that's really all. I'm happy to take any comments or corrections if somebody else does the math and is correct and can correct me, but those are the numbers I got.
Dr. Coleman.
Yeah, I just wanted to follow up on that. That has been one of our discussion points internally. When Accord Lipid and Aim High and Thrive didn't show benefit, they had baseline had people on fairly low levels of LDL. In a couple of cases, well below 100. Some people thought maybe that explained why the second agent didn't work. So one of the things we did note about jealous is their LDL levels are far, far above that. And is it then really the same paradigm relative to what they'll be doing in reducing?
Yes, comments from the sponsor?
So one aspect regarding jealous is, of course, as you mentioned, their LDLs were higher. And reduce it, obviously, the dose of EPA is double that. We also are talking about a patient population that will, for the first time, be greater than or equal to 200 milligrams per deciliter in terms of triglycerides. And so, all of those trials that were on that slide, Aim High, Accord, we agree, we understand there's a murkiness. There's, and always when you're doing sub-analyses or post hoc types of aspects, there are significant limitations. But what gives us confidence that the lipid effects in that table 1 are reasonably plausible to translate into a cardiovascular benefit? There's an element of jealous there in the sense of, too low a dose of an omega-3, similar to GCP, similar to some of the other omega-3 fatty acid trials. Importantly, the actual true need in a elevated triglyceride patient population as opposed to looking at it post hoc. And then the other thing to remember is niacin is not the same type of a molecule as fenofibrate as EPA, right? EPA, unlike some of these other agents, is broadly incorporated into tissue membranes throughout the body. So there is, without it being concrete, we would say that with the safety and tolerability profile and the efficacy profile across a range of lipid and lipoprotein parameters and this other tissue distribution, that there's a plausible benefit that can come from reducing.
So we'll now break for lunch. Thank everyone for the very informative discussion. We'll reconvene again in this room in 1 hour. That will be exactly 12:45. Please take any personal belongings you may want with you at this time. Committee members, please remember that there should be no discussion of the meeting during lunch amongst yourselves, with the press, or with any member of the audience. Thank you.